Hello everyone, my name is Jeanna Holtz and I would like to welcome you to today's technical briefing hosted by USAID's Health Finance and Governance Project. HFG is a 5-year global project that supports low and middle income countries to pursue universal health coverage while expanding access to priority health services and improved health outcomes. Today, HFG will share lessons learned and technical insights from our work in supporting 2 countries, Ghana and Ethiopia, as they each chart their own course to advance toward UHC. I'm delighted to be joined by 2 of my colleagues today who are experts in health financing and who are very involved in the work that's taking place in HFG's country programs in Ghana and Ethiopia. I'd like to introduce right now Chris Lovelace. Chris?
Good morning, everyone.
And our second presenter is Hailu Zelelew. Hailu?
Good morning, everyone.
Welcome to both of you.
Thank you.
The briefing is going to last 1 hour. Each presenter will keep his remarks brief, and he'll share selected highlights about each country's context and its efforts and challenges to move toward UHC. I invite our listeners to submit questions at any time. You can do so by typing your question into the question pane that should be visible on your screen. With good luck, we plan to have about 30 minutes for Q&A following both of the presentations. And we'll try to get through as many as we can in the time that we have. So, a few introductory remarks from my side to kick things off. Reports show that there are more than 100 countries that are home to almost 3/4 of the world's population that have taken steps toward UHC. But we also know that making this kind of progress is really hard. It takes time, it's uneven, and it's unpredictable. But that said, UHC is now squarely part of the global development agenda. Many of you will be familiar with the Sustainable Development Goals that you see here, and which were adopted by the UN last September. The SDGs include a goal for health, and under that goal there is a specific target to achieve UHC. I also wanted to share a quote taken from a recent paper that's authored by senior leaders from USAID and that aligns with the aspirations of the SDGs. The quote underscores that USAID's own goals for international development and for poverty alleviation and to achieve specific global health objectives all rely on countries being able to progress toward UHC. It's also helpful to be reminded of some of the core concepts that define UHC. UHC is an aspirational goal. In reality, it's never fully achieved, and this is because it's not possible to pay for all services for all people all of the time. Rather, countries are at various stages of moving closer to this goal. Many of you are also familiar with the WHO's coverage cube that you see on this slide. The cube reminds us of 3 core dimensions that comprise UHC and which our presenters will be talking about today. The 3 dimensions are population coverage, service coverage or access, and financial risk protection. Providing access to needed services and financial risk protection are pillars of UHC, but there are other crucial elements that our presenters are going to touch upon. These include equity, quality, responsiveness, and the financial sustainability of programs. One of these important aspects is equity, and in particular, that resources are shared equally by everybody, including the poor and the vulnerable. So this version of the cube shows a hypothetical view of how the 3 dimensions of UHC might look across different income groups. In this example, the wealthiest group, which is in the green slice, enjoys the highest service coverage and financial protection, while the poor, which is the orange block, have the least. This is unfortunately one scenario that many countries struggle to address. Another common remark about UHC that I think bears repeating is that there's no single pathway followed to achieve it. The unique pathway that each country follows is determined by its own context, resources, politics, social values, and other factors, as we'll hear about in today's presentations. A final point that I'd like to add is that many, but not all countries use insurance as a financing and risk pooling mechanism to provide access to health care and financial risk protection. Ghana and Ethiopia are two examples. Others choose different mechanisms, such as publicly funded healthcare systems, where care is free at the point of access, and often they are using a mix of different options and alternatives. So now let's turn to the country cases and get into those. We'll start first with Ghana. Chris, over to you.
Thanks, Jeanna. We can go to the next slide right away. What I'll be discussing very briefly, we have 10 minutes to do, is to introduce you to both Ghana and the National Health Insurance Scheme, talk a little bit about the achievements to date. It has a long history. Some of the key challenges, but in particular the financial sustainability that is very pressing on the NHIS. Talk a little bit about the approach that the NHIA is taking to improve expenditure management, and then introduce you to a major national review that's underway in Ghana that will chart their course for future enhancements toward UHC. Ghana is classified as a lower middle income country with about 27 million people and a GNI per capita of around $1,590. It's a resource dependent country, both natural resources such as cocoa, but also gold, diamonds, and more recently, the last 10, 15 years, oil and gas. With dependency on commodities, of course, comes both the advantages when commodity prices are rising and the challenges when they're falling. And Ghana, like many oil gas dependent exporting countries, is struggling now with the depressed price of petroleum. It has fairly typical for a lower middle income life expectancy, under 5 mortality rates, is a significant portion of its population under 15, and it's quite highly urbanized. In that sense, reflects where much of the world is going in terms of becoming increasingly urbanized. Reforms in the Ghana health system are new. In fact, in 1957, the year that Ghana became an independent country in the post-colonial period, one of the first in sub-Saharan Africa, the official policy of free healthcare was introduced. And if that by itself was sufficient, Ghana would have already achieved universal health coverage. We know that's not the case, and over the preceding or succeeding decades, Ghana has gone through various reforms attempting to improve the health system and access to health services. Some have actually been stepped backwards, like the introduction of cash and carry in the 80s, fundamentally excluded the majority of people from accessing health care. Cash and carry means you pay for the service on the spot when it's delivered, by the way. Others were innovative for their time. In the 1990s, the introduction of community-based mutual health insurance schemes were introduced, and later they were abandoned. And in 2003, the National Health Insurance Scheme was introduced and has been in operation since then. So they've recently celebrated their 13th anniversary. The NHIA was, as I mentioned, established in 2003, and its stated purpose was to secure financial risk protection against the health costs of healthcare and to expand access to healthcare services. It's some hybrid model. There are characteristics of the beverage system, that is to say, publicly financed. In the case of Ghana, publicly financed through a 2.5% VAT tax, or 2.5% of the VAT tax. Bismarckian in that contributions are made through the Social Security system to those who contribute to it, and it carries forward some of the features of the mutual system that it replaced in 2003. You can see, however, that it's predominantly financed by, in the pie chart, by the VAT tax and the Social Security contributions. If we could go to the next slide, please. It's grown remarkably since its inception. in 2005, when the scheme was fully operational, there were approximately 1.3 million active members, and today they're 10.2. Having said that, that still is only 38% of the population covered. Similarly, outpatient utilization has grown enormously from less than 600,000 visits per year to nearly 30 million. Inpatient services similarly from 29,000 to 1.6 million. And claims payments have risen from 7.6 million CDs to nearly 1 billion CDs. So remarkable growth, but very clearly not comprehensive coverage yet, certainly not achieving UHC yet, although legislatively the frameworks suggest that anyone can register, and premiums are not particularly an obstacle to access to care, but there are clearly obstacles to having everyone enrolled, notwithstanding the fact that the legislative framework would certainly allow that. Next slide, please. Thank you. There are clearly achievements that can be attributed to the NHIS, including improving health-seeking behavior, and you can see that through the dramatic growth in utilization and membership. For those who are covered by the NHIS, it shows positive risk protection. As to say, out-of-pocket payments are significantly less a part of members' expenditure pattern than they are for non-members, so that those who are involved in the scheme do receive a degree of financial risk protection, although there are still fees and charges and financial obstacles even for those who are covered. In terms of challenges looking forward, and we'll talk a little bit more about this later in my presentation, there are certainly challenges of financial sustainability. There's a concerning lack of cost containment that jeopardizes expansion of the system to cover more people. There are slow growth in terms of expanding membership in recent years, something of a plateau around this 35 to 38 to some suggest up to 40% coverage, but that's not anywhere near 100%. There are issues related to equity in the coverage, although not as extreme as one might have thought. And there are issues related to the coverage and its relationship to quality of care. Ghanaians and NHIS and the Department of Health in particular are very aware that on one hand, there's much to be learned from their experience, good and bad, and on the other hand, there's much they need to learn from others. So Ghana is, for example, a very active participant in the Joint Learning Network. This is a really interesting table. It shows the growth of both income and expenditure in CDs for the NHIS. And you can see in the early years, all the way up to 2008, revenue actually exceeded expenditures. And the NHIA accumulated in the trust fund significant reserves. From 2009, however, expenditures have exceeded in each and every year income. And you can see that the disparity of it has actually been increasing as well as a general trend. And clearly, in the long run, that's not sustainable. In fact, the reserves have largely been exhausted. And looking forward, there needs to be some squaring of the circle between expenditures and income. And this will be one of the fundamental challenges Ghana will be facing going forward, and one of the reasons why they've initiated a major review. On the previous slide, just to perhaps draw the obvious, one of the reasons you have this difference between income and expenditures is that the two are unlinked. The contributions through Social Security and the contributions through VAT are automatic and very much directly linked to the economy and how well it's doing, particularly the VAT, whereas the expenditures are related to demand, and the two are unrelated. Unlike a system that primarily depends on premiums, that you could adjust the premium basis and keep your income in line with your expenditures. So it's an asset in some ways. There's predictability in terms of revenue, and you can see revenue has grown in each and every year, and actually shows a fairly healthy growth as the economy of Ghana overall has generally improved, and in recent years has been growing at in excess of 6%. So that's the good news, and the bad news is the expenditures have exceeded that. Okay, sorry, next slide, please. So to address this, the NHIA is attempting to move from being a passive payer of bills using a fee-for-service type of system to more of an evidence-based strategic purchaser. That's being done through improving expenditure management and control to contain costs, make sure things that are paid for are provided, that there's no duplication, there's no inefficiency in the way that their processes work, and that opportunities for fraud or misexpenditure are reduced. They also are attempting to become a purchaser, moving away from fee-for-service type structures to those that allow a stronger focus on achieving health outcomes and allow better targeting of ensuring access to the necessary services and eliminating those things that are possibly less value producing. And within that, using evidence to inform their decisions about how they might structure payments to create incentives, how they could monitor and make sure that those outputs and outcomes are being achieved, and how to fine-tune the system to make sure that the intended benefits are provided and those that might suggest duplication or inappropriateness are eliminated. And the NHIS review that's presently underway is part of that as well. And one of the objectives, actually it's a twofold objective. First, that the scheme be financially sustainable, and that's a major challenge. From the previous slides, you will have seen that they're tracking toward insolvency. And secondly, that they break through the ceiling and expand coverage from the current 38% to something that reflects universal health coverage, at least for a core set of services. Next slide, please. So how are they doing that? First, in primary care, they're moving away from a fee-for-service reimbursement system to a capitation system. They piloted a few years back, a pilot in Asante region. From that, they took many lessons and presently are rolling out capitation in 3 other regions. And the capitation is being built around those lessons learned from Asante, including the need to establish preferred provider organizations to make sure that the potential downside to capitation, lack of incentives to provide care, for example, are addressed, and to make sure that both the providers and the public are aware of capitation and what it implies and how it would work, both to the benefit of, first and foremost, the public, and secondarily to the providers in creating incentives for them to treat the person and the family and move away from episodic treatment simply based on presentation. On the inpatient secondary tertiary side of things, they are in the process of revising their Ghana DRGs that have been in place for some time but have primarily been used as just another method of providing fee-for-service reimbursement to providers, and instead are trying to use the DRG as a comprehensive payment mechanism to ensure that all services related to an episode of care within that DRG are included, irrespective of secondary conditions, irrespective of complications and the like, to make sure that by financing through DRGs, you capture the efficiencies that potentially are there in the holistic approach toward case management, and also to do so in a budget neutral sort of way to make sure that the cost containment objectives are achieved and that there isn't multiple claims against that DRG for the same patient simply because they're presenting with other secondary conditions or require secondary sources of treatment and the like. So a very important initiative, relatively newly underway, but over the next year or two we would expect to see significant benefits from moving in that direction. Internally, they're enhancing their claims management and costing system. The system is in some ways sophisticated, but it's based on collection of claims at a regional level, then consolidating those claims and forwarding them, and then payments, and it's both inefficient in terms of cost and timeliness, and it's also inefficient in terms of making sure that only those things that are appropriately claimed are paid for, and that where there's inappropriate patterns of practice, whether intentionally or unintentionally, those are captured and directed, and that areas that are either underserviced or overserviced can be identified, informed by evidence, and the scheme can be restructured in order to ensure that the claims management process addresses those things. And then, of course, they're engaged in active policy dialogue and collaborations with others. And one of the attributes of the NHIA is that they have regularly reached out. December 2014, for example, they had a major stakeholder consultation on the benefits package, which is very broadly cast, inclusive of almost everything, but not terribly well defined, and is one of the issues as to whether or not that needs to be more tightly managed, more tightly defined, and then ensure that it's actually available to everyone. That's an example. The current NHIS review that I'll come back to later, also a good example. But the approach basically is that through strategic purchasing, you can, what we call, close the hole through efficiency gains, and there are substantial opportunities for improving the performance of the National Health Insurance Scheme that will reduce the financial sustainability issues and at the same time improve access to services and provide space for expanding enrollment. On the evidence side of things, we have been, the NHIA has been focusing on improving management information through development of a dashboard, introducing rapid operations research to better inform their decision-making processes and look for opportunities for improving services. They've introduced a comprehensive monitoring and evaluation policy, and that's being rolled out, and monitoring and evaluation has been escalated in the organizational hierarchy to reflect its importance, and they've tried to take advantage of learning and knowledge exchange opportunities, and again, participation in Joint Learning Network is a good example of that. A recent exchange with the Taiwan National Health Insurance Agency is another good example of that. GHAN has shown some real leadership, both in terms of welcoming others to see their system, but also trying to learn from the experiences of others. Next slide, please. This is the last slide, and I will go through it very quickly as my time is being exhausted, but there is a major national review underway of the scheme. It's composed of a technical review committee of senior health professionals led by Dr. Chris 18, but with prominent people including the CEO of the NHIA. They will be producing a report that will then be considered by a broader-based advisory committee that will make, in turn, recommendations to the government. This review was established by the Office of the President, has very high profile, and is being supported by both the government and the opposition. Final report is expected sometime in mid-2016.
Great, thank you very much, Chris. We'll move into our second presentation. So Hailu, I would like to invite you now to talk to us about the experience of Ethiopia.
Thank you, Jeanna. So my presentation on Ethiopia will focus on first giving you a general background about Ethiopia, about the Ethiopian health system, especially before mid-1990s, and also introducing some of the initiatives, including the financing reforms and where Ethiopia is currently in terms of health outcome trends. Then my focus will be more on community-based health insurance in the subsequent slides. Ethiopia is the second largest country in terms of population in Africa, with a population of close to 100 million. It's relatively predominantly a young in terms of population age. Life expectancy has substantially improved in the last decade or so. Still, it's a high poverty country, a poverty level of around 29.6%. Low-income country with per capita income of GNI of 550 in 2014. And unlike Ghana, you saw from Chris' presentation, Ethiopia is predominantly a rural country with more than 85% of the population living in rural and informal economy. When the different reforms started in the early 1990s, Ethiopia has limited physical and financial resources in the health sector. There was significant shortage of operational budgets, and essential drugs were not available. There were also misallocation of resources, like in some facilities you see staff, but there were no operational budget to buy essential drugs or to function the facilities. It was highly decentralized country, and sustainability of the health sector was in a very low situation, and it was frustrating. There was high inequality, as the services were available more in urban settings for relatively better of population. So in 1990s and early 2000s, Ethiopia introduced a wide range of reforms. As you can see from health expenditure side, in mid-1990s, like 1995-96, per capita spending was very low, $4.5 per capita spending on health, which is maybe one of the lowest in the world even by then, and still is low, but it has substantial progress in the last 10 years or so. So in 2010-11, the per capita spending goes around $21. Regarding source of spending, like in 2010, the bulk of the money was coming from the rest of the world, which is donor money. About 50% of the funding for health was coming from donors. Households were the second largest financiers of health, like around 34% was covered by households. Government covered around 16%, and other sources, it was very insignificant. In terms of the different initiatives in Ethiopia, I think it's good to make it clear that when we talk about universal health coverage, we need to see different aspects of the universal health coverage, including increasing access to health service, increasing the population coverage, and also the financial protection aspect, as Jeanna mentioned earlier in her highlights. So regarding that, Ethiopia substantially expanded health services. As you can see, as many of you may know, Ethiopia introduced a new innovative flagship program, the Health Extension Program, which enabled the country to assign to health extension workers per village. And in the last 2 decades, this number has increased from 0 to 42,000 health extension workers. In terms of health facilities as well, as I mentioned, the health posts for the health extension workers stations, but also Ethiopia substantially increased the health centers. In mid-1990s, there were only 300 health centers, but as recently as last year, this number has increased more than tenfold. And then Ethiopia introduced the Health Sector Development Program, which was key in terms of prioritization of services, including focusing on preventive and promotive healthcare. From financing side, there were different reforms introduced, including harmonizing and alignment of donor resources, and also donors and government agreed to establish the Millennium Development Goals Performance Pool Fund, which was a huge amount of resources and key to cover priority areas. And Ethiopia also introduced a few-ever system for the poor to give protection, financial protection for the poor, while also expanding priority service through free provision of services. This includes like immunization, maternal health care services at primary health care unit levels, and other services. And another important development in Ethiopia is the decentralization of the health system as part of the overall government decentralization. and district level planning and budgeting was critical, and that enabled to prioritize services at facility level and also at community level. And another major development in terms of financing is to allow health facilities to retain and use the fees that they collect from users. And that was important in terms of filling the financial gaps. In the last 10 years or so, the major new development that's coming into Ethiopia's health financing system is health insurance. In terms of health outcome, Ethiopia showed tremendous progress. I mentioned the life expectancy has improved significantly, and also Ethiopia achieved MDG4 in 2012 before, which is before 2015, and also Ethiopia showed significant progress in achieving towards achieving the reducing the maternal mortality and also improving sanitation and hygiene services. Coming to the community-based health insurance, why community-based health insurance in Ethiopia? One, as I mentioned, Ethiopia is a predominantly rural and informal economy-based country. So greater than 85% of the population is in rural and informal settings. And again, as I mentioned, household spending, even in this highly donor-financed health sector, is still significantly high, like 34% of the health expenditure coming from households. Even though there was significant expansion of health services utilization was still very low. And from the opportunity side, Ethiopia has a strong community-level solidarity system, which was critical in terms of serving as a foundation for introducing community-based health insurance. So starting from the mid-2000s, Ethiopia started working on the health insurance broadly and also community-based health insurance specifically. In relation to that, I think as Chris was mentioned, one of the oldest health insurance experience countries was Ghana, and Ethiopia visited, the people from Ethiopia visited Ghana, Rwanda, Senegal, Mexico, and other countries to learn from their experiences. And different policy documents were produced, and in 2008, the health insurance strategy was developed, during which government decided to establish two different health insurance schemes: the social health insurance for the formal sector and community-based health insurance for the informal sector. So first, to draw lesson and also to contextualize community-based health insurance, the government decided to pilot community-based health insurance, and certain districts in the largest 4 regions were identified, and starting from January 2011, piloting was conducted in those districts. And we had evaluation by independent evaluators in 2014. So this is the highlight of the evaluation. As I mentioned, it was piloted in certain districts. The population, the average population in each district is around 140,000. So the pilot districts had a total household size of 300,000, which is a population of 1.8 million. In terms of the actual performance, the contribution was made from households, which accounted about 52% of the fund, and also government subsidy accounted 48% of the total fund through targeted subsidy for the poor and general subsidy for the schemes, so that to cover any shortcomings in running community-based health insurance schemes. And I think, as Jeanna showed in the cube, one of the most important things is to see who is covered in the financial protection program. So in the CBHI schemes, one of the important developments is to provide coverage for the poor through government covering the payment for that group. In terms of enrollment coverage, about 52% of eligible households in the pilot schemes were covered through the community-based health insurance. That is the average of the 13 districts. We see there were up in some districts as high as 100%, but in some there were 25%. But overall, there was an average of 52% coverage, and 157,000 households and over 700,000 beneficiaries were covered through the CBHI schemes. And 15% of the enrollees were poor, whose payment was covered by government. Another great lesson drawn or achievement from the community-based health insurance was utilization among the CBHI members and beneficiaries has substantially increased. Like as I mentioned, health service utilization was only 0.3 per annum, which is 1 out of 3% visiting health facilities, whereas among the CBHI members it increased to 0.7, which means almost 1% is visiting annually health facilities. So the health-seeking behavior has substantially improved. The poverty, the financial protection aspect is also another important achievement from the CBHI schemes. As you can see it from among the CBHI members, out-of-pocket expenditure, which exceeds 15% of non-food expenditure, was only for 70% of the insured, whereas for non-insured it was 19%. So the financial protection was significant. However, still there are major challenges. Like one of the challenges is there is low membership renewal among CBHI members. It could be different for different reasons, structure and other things. But the survey showed there is interest to renew their membership. Also, new enrollment is very low. But again, the evaluation showed among non-members there is interest to increase their enrollment into the CBHI schemes. We observed some schemes are experiencing financial difficulty, like spending more than the amount of revenue they collected, especially in urban settings. We also learned from the evaluation the local officials' commitment, which is an important ingredient for the community-based health insurance schemes, varies from locality to locality. And again, facilities also differ in their readiness to deliver quality. It includes availability and quality of staff, medicine, laboratory facilities, and other aspects. And also inadequate mechanisms to address complaints. Final point is, what are the current developments? We saw the evaluation, but what are the current developments? One, government is satisfied by the pilot results and decided to scale up community-based health insurance. So in the last 2 years, a total of 185 new districts are establishing community-based health insurance schemes. And in fact, this year, additional 131 districts are launching community-based health insurance schemes. So as of today, as of the end of last year, as of end of December, 1.6 million households and 7.3 million beneficiaries are enrolled and covered through the community-based health insurance schemes. And on average, 22% of them are poor, whose premium is covered by local government. The pilot is about to start in urban settings and pastoral areas, as the certain CBHI pilot schemes focused on the agrarian areas. And it has significant resource implication, and government is ready and willing to commit that resources. So to implement the scale-up strategy is developed, and directive for its implementation is also developed. In the government's health sector development plan, the plan is to increase the district coverage to 80% and also the population coverage to 80% of the population by 2020. And in fact, recently they were also discussing even to reach all districts, which means 100% of the districts, 80% of the population by 2020. I think in terms of lessons from Ethiopia, I think CBHI gives significant coverage mechanism and can be served as a pathway to UHC. And as I mentioned, it provides financial risk protection, including for the poor. It enhanced her service utilization and the quality, even it created some pressure on health service delivery, and quality is improving in health facilities. It requires strong government commitment, and that I think other countries can learn from the Ethiopia experience in terms of that, and partner support is always critical. I think in Ethiopia, the subsequent USAID project has played a significant role in initiation and implementation of community-based health insurance. Thank you very much.
Mm-hmm. Thank you, Hailu. We will, I think, begin with some questions that have come in from our listeners. We're just sorting through these right now. Why don't we start with one just as a follow-up for Ethiopia and Hailu's presentation. So the question is, Hailu, around how does enrollment take place and how does it work in Ethiopia? Is it mandatory or voluntary? And how do subsidies that the government provides, how are those subsidies distributed?
Mm-hmm. Thank you very much. I think in terms of the first case, as I mentioned, Ethiopia is predominantly rural and informal country. So the decision for the government is to start enrollment or the CBHI scheme as a voluntary scheme. And so far it's voluntary, and as I mentioned, the coverage has increased to 52% on average, but there is significant variation from district to district. But so far, and the policy direction so far is to continue it as voluntary scheme. But I think as lessons are learned, the possibility of introducing other ways of increasing the enrollment, including considering maybe some incentive or some way of voluntary mandatory system could be there.
Okay, thanks. Let's go to Ghana and call on a couple of the questions that we have for Ghana right now. Chris, if we have a question really about the evolution of the NHIS. And the question is, could you expand on how the historical presence of community-based health insurance schemes evolved into the NHIS? Maybe tell a little bit more about how that occurred.
Sure. CBHI schemes in Ghana never were comprehensive in terms of covering all of the country, and they had considerable promise, but always struggled both with enrollment and income, and never really fully achieved their objective, although they had considerable promise. So there was both a problem in terms of the comprehensiveness, the financial protection. They were contributory schemes, so there were financial barriers to access. And I think at some point, the government realized that if they wanted to have a comprehensive national scheme, it was not going to be made up of individually established CBHIs, but rather could be built upon that as a starting point and move toward a national system. So that's what they did. It was part of the political culture of the time when the NHIS was established. It was very much a plank in the government's program, and has evolved ever since. So CBHI could be seen as a building block toward achieving a national health insurance scheme. Lessons were taken from it, but it was viewed as something that by itself was not going to be long-term sustainable.
Mm-hmm. And maybe just as a follow-up to that, the question is about the governance of the NHIS. Is the NHIS managed by the Ministry of Health? And is there a purchaser and provider split?
Thanks, both of those good questions. NHIA is officially a part of the Ministry of Health, though it functions autonomously and it has an independent board over top of it. So there's the senior management and then there's an appointed board that is overall responsible for its operation. Sorry, what was the second part of the question, Jeanna?
The second part was,
yes,
exactly.
Yes, absolutely. In fact, baked into this model is that the NHIS and the NHIA, which is the executive agency that oversees it, is the purchaser. It provides no services itself. It makes payments to the providers. So it is quintessentially the purchaser-provider split.
Mm-hmm. Great, thanks. This is a question that maybe can be answered by both Chris and Hailu. How are Ethiopia and or Ghana dealing with issues around retention rates and renewals of members? Hailu, would you like to respond to that first?
Yeah, that's a great question. As I mentioned, it's one of the challenges in Ethiopia, but government is working with the CBHI schemes to maintain and also even to increase enrollment through using local community-based and government structures. And the CBHI structure itself is being strengthened so that there is continuous renewal, follow-up, and registration of new members. So government and the CBHI schemes are working on that.
Mm-hmm. And Chris, from the Ghanaian perspective?
In Ghana, individuals need to register at one of the regional or district level NHIA offices, and they have to be current in their payments of premiums. Both of those represent challenges. Obviously, there's not an NHIA office in every town and every village. And secondly, although premiums represent less than 4% of the income of NHIA, for an individual or individual household, it could represent a financial barrier, though the premium rates are set very low and there are exceptions to the payment of them. So both of those things need to be addressed. They're almost certainly going to be addressed in the NHIS review that's underway, and options could include everything from moving away from the premiums entirely to the extent that that's an obstacle to enrollment, to separating enrollment from payment of premiums so that once you're enrolled, you remain enrolled irrespective of whether you're active or non-active in the scheme. And there are other issues that could be addressed, but it's an area that I think in order to expand beyond that 38%, there needs to be a reach-out mechanism. Technologies also offer a lot of opportunity. Maybe people could be registered at the point of service if they're not already registered, for example. With mHealth and eHealth opportunities and the like, registration doesn't necessarily mean physically presenting yourself at a place. It could be done in more efficient ways, and I'm sure all of those things are going to be considered in the context of the review.
Thank you. This is a follow-up question for Hailu about Ethiopia. So Chris had elaborated on the sort of historical context of community-based health insurance schemes in Ghana, and one of our listeners is asking, is there a plan to integrate the CBHI schemes into a singular larger risk pool? And what might be the challenges or opportunities for doing that?
Yeah, that's another great question. For Ethiopia, CBHI is part of the Universal Health Coverage Agenda from the financial protection point of view. So it's a government-initiated, government-supported initiative, and going forward, higher-level risk pools are being institutionalized, like to have a regional level association of networks of CBHI schemes. And then in the long term, the plan is to have a unified insurance, social or national health insurance, by which the formal sector, social health insurance, and the informal sector, community-based health insurance, will be merged. But that will be a very long-term vision and long-term plan, whereby when the economy is improving and more the formal sector is increased, and also the per capita income or income of households is improved through time.
Thank you, Hailu. We have another question, a broad question coming in, I think directed first perhaps to you, Chris, about Ghana. And it's about financial sustainability. So you talked a lot about some of the challenges that Ghana is facing and some of the approaches that they're taking to try to address these issues. What are some of the key strategies that as Ghana is working on cost containment to expand coverage, to expand population coverage, if I'm understanding this question correctly?
Right. Well, there's two aspects. Thanks for that, and that makes sense. It's a good question. There are a couple of dimensions to it. First, in order to expand coverage, you need to have the fiscal resources to do that, because expanding coverage will almost certainly increase expenditures. So on the expenditure side of things, creating efficiencies or achieving efficiency gains through moving towards strategic purchasing, to better claims management, to moving away from open-ended fee-for-service, to considering the scope of the benefits package. All of those things could create fiscal space, if you will, within the current revenue envelope to expand coverage. On the revenue side of things, of course, there are also options to increase revenue, but those come at the expense of other priorities within society. So the two go hand in hand. First, drive out the efficiencies, enhance the ability for people to enroll, manage the costs in a way that doesn't compromise either access to comprehensive services or quality, but at the same time drives out the inefficiencies and moves to things like capitation, are designed to encourage that. Comprehensive DRGs as a purchasing vehicle enhances that, so that it creates the space for expanding membership, and then there needs to be an outreach mechanism that's more efficient than the current way of registering and tying registration to premiums, in order to make sure that all who wish to be covered can be covered.
Great. Thank you, Chris. This is maybe a follow-up question around cost containment and financial sustainability. The question is, what is the dominant provider payment system in Ghana and Ethiopia? I think, Chris, you spent some time talking about that and may want to highlight a bit more about the way in which providers are paid. And Hailu, just to maybe spend a few minutes talking about that aspect of Ethiopia's. The listener also asked, how do these provider payment systems, whatever they may be, affect moral hazard or have an adverse effect on providing care on the provider side? So to what extent might those influence access to care? Hailu, would you start? Yeah, go ahead.
Yeah, I'll be very brief because much of my presentation actually dealt with this. The current system is primarily a fee-for-service system, and it's open-ended. Payments are made to providers who provide services based on claims submitted that evidence of the service has been provided. There are no real breaks on that system other than sort of audit types of checks. Men don't deliver babies, for example, to take a silly example. But other than the sort of fraud and abuse or misuse kind of audit functions, basically if a service is rendered and it's included in the package, it's paid, whether it was done repeatedly or appropriately or in the right context and the like. They want to move away from this basic fee-for-service type of reimbursement system toward one that is more focused on purchasing to make sure that appropriate services are provided for and paid for in a comprehensive way that can increasingly become budget neutral.
Thank you, Chris. Hailu, anything?
Yeah. The provider payment mechanism in Ethiopia as well is fee-for-service currently, but Ethiopia is also exploring different options, including considering capitation at primary healthcare unit levels and also even for outpatient at hospital levels. So that is evolving. It's a very good question, but Ethiopia is learning and keep improving, and possibly different provider payment mechanisms will be introduced. So that also to contain the moral hazard issues and adverse effects of providing care.
Thanks, Hailu. I think we have time for maybe 2 more questions before we need to close. So let me come to another topic about quality. He has asked, what is the role of quality and how are each of the countries and their efforts to achieve universal health coverage, how are they assessing and managing and working to improve quality? Chris, would you like to go first?
Well, another really great question, and I wouldn't say that Ghana is necessarily leading the pack on issues related to quality, but quality and incentives from payment systems do go hand in hand. For example, the capitation system that's being rolled out in Ghana has an emphasis on managing the person's health toward a good outcome. Embedded in that is quality. The more you can prevent illness or treat it early on an early onset in an integrated way, the more likely you are to be able to manage the costs, which in a capitation system, the provider has all the incentives to do, because if they don't manage the costs, they don't get paid more. Unlike a fee-for-service system, if you have a repeat visit, you get paid for every visit. Within a capitation scheme, you get paid an amount to care for that individual, irrespective of whether they have health incidents or not. So there's an incentive to keep people as healthy as possible. So that's an example. DRG payment mechanism as opposed to a fee-for-service mechanism similarly says within this primary diagnosis, this DRG, there's a single payment and all related care requirements have to be included within it. So again, there's an incentive to manage the person as a whole in order for the provider to get maximum gain out of a fixed DRG payment amount. So the two are interrelated for sure.
Yep. Great,
quality
great
more generally, I think, is a broader issue of stewardship that the Ministry of Health, professional associations, and others all have a role to play. But within that plethora of interested parties, the NHIS and the NHIA have a role to play by ensuring that the payment mechanisms and the management of claims incentivize producing good outcomes, which is a surrogate for good quality.
Right, thank you. Hailu.
Yes, yeah, that's another great question. Yes, quality is very important, and also in the case of Ethiopia, in fact, when the community-based health insurance piloted in certain districts, one of the primary things that Ethiopia did was to assess readiness of facilities, including assessing the quality of the health system. And then also government, the ministry invested a little bit on all those health facilities in the CBHI districts to make sure the facilities would be ready to provide services. And now quality is a big issue for the Ministry of Health, one of the major pillars of the health sector transformation plan, which is a sector development plan. And quality and health insurance go hand in hand because of the demand and pressure from the CBHI members and other health insurance members as well.
Okay, thank you, Hailu. I think we're running out of time, so we'll stop our questions there. I'd like to once more say thank you to our presenters, Chris Lovelace and Hailu Zelelew. Thank you very much. We also wanted to share some resources for those who would be interested to learn more about some of the experiences that Chris and Hailu have highlighted in their presentations this morning. So those are cited here, and they're on the HFG website. Thanks again very much. I think from my side, this has been, it's always interesting to delve into the particular context and sort of hear the story about how a country's progress toward achieving UHC evolves and where it's headed. But as well to have two examples side by side and to see where there are certainly common themes that each of them are grappling with, related to expanding population coverage, for example, and making sure that the schemes are equitable and that they're reaching as many people as possible and that they remain financially sustainable. And I'm also reminded by the fact that these are works in progress and they take a long time. So look forward to continuing these stories and building upon them, and I would like to thank everybody for joining this briefing today. Have a great day. Thank you.